Ma'am, the session is live now.
Good evening, everyone. Of Women Ophthalmology Society, it's pleasure to welcome you all to this important academic discussion of WOS Teacher Connect Program Step 5 on postgraduate assessment, an area that directly shapes how we train and evaluate our next generation. So NMC has given us CBME, and we all are implementing it in undergraduate teaching, but it still lacks to some point in PG teaching. So today's session will focus on making assessment more objective, structured, and not just a formality, but a true tool to assess our residents. We are grateful to our special guest, Dr. Partha Biswas, President AIOS, Dr. Sujata Das. We welcome you, Madam. Dr. Rajesh Joshi. We welcome you, Dr. Joshi, to this webinar.
Thank you
for joining us today on a working day at 8 p.m. when it's dinner time. We are also privileged to have eminent teachers from around the nation. Dr. Swarna Biseria, Madam, Dr. Urmil Chawla, Dr. Manisha Rathi, Dr. Devang Engmo, Dr. Jigisha Sharma, Dr. Rupali Chopra, Dr. Pooja Bang, Dr. Soumya Dulani, Dr. Shweta Patro, and Dr. Vibhuti Kashyap. We welcome all the panelists. So we are very much honored to have you all over here, and myself, Dr. Shweta Walia, with our co-moderators, Dr. Swati Tomar, Dr. Ragini Parekh, Dr. Subneshwari, and Dr. Maya Hada, will take this session and try to make it thought-provoking and keep the discussion live. So if all the panelists and speakers are ready, we can start the session. The last session, that was step 4, was on wet lab, establishing a wet lab. And we have rapporteur of that session, Dr. Aditi Dubey, with us, who will sum up what was discussed in last session, and then we can begin this session. Dr. Aditi, are you ready?
Yes. Am I audible?
Yes, you're audible, and you can start sharing your screen.
Okay. So is my screen visible?
Yes, it's visible.
Yes.
It's visible.
Okay.
Get started. So,
okay. So first of all, I would like to thank WOS for the opportunity. I would like to sum up the previous session, that was step 4 session, where in WOS Teacher Connect program, we talked about setting up a wet lab, how it is important for postgraduate training, the infrastructure, instrument, and its sustainability. So a very nice session was taken at that time. We had video and presentation. So I have taken a few points from that session to present in front of all of you. So first of all, why do we need wet lab? It is not only that the NMC or CBME curriculum says that we need that, but it also helps for a safe surgical development. It provides a risk-free environment for the residents to get trained. They can make mistakes, they can repeat their mistakes, and they can learn from them. So in that way, it builds confidence. Also, because ophthalmology is different from other type of surgical branches, where it is microsurgery. Every time, everything is not visible. Your mind has to know and look for it. So in that case, it improves the hand-eye coordination. It helps them how to handle the microscope. It develop their fine motor skill along with the gross motor when they have all their 4 limbs working together. It is also a stepwise learning of the surgical technique, that we have to do this, then this, then this, and then this. Similarly, they understand the instrument handling, and all of this, in short, it improves their surgical outcome. Their learning curve on patients decreases because they have practiced that multiple times in the wet lab. It bridges between theory and live surgery, because when we teach, we tell them that, okay, you have to make rexus, you have to do this like this, your hand movement should be like this. But when they sit and they do, then the gap is bridged. Confidence building, decrease anxiety, and along with that, they learn how to also innovations and experimentations. So, talking about development of wet lab, the first and foremost is the infrastructure. Here you can see the wet lab at GMC Bhopal. We have a small wet lab designed for the students where we have one spare microscope attached with a screen, a trolley having basic instrument, AC, and a surgeon's chair, table, etc. So, first of all, infrastructure for that space, a dedicated space should be there. It should be 10 by 10 feet and ideally in the main building so that the residents, whenever they get time in between the duties, they can go and practice something. For equipment, because we are ophthalmologist and the surgeries are microsurgery, so operating microscope is a must. Along with that, if we are trying to teach the resident, a side scope or a camera with screen is something that is very essential. The basic surgical instruments, the phaco machine with tubings, and if possible, audio-visual aids for demonstration of recorded videos, or resident can record their videos and then discuss with the mentors also that what they have done and what were their difficulties, because all the time mentors and resident might not be present. Also, one of the important aspect in this is the biomedical waste management. So that should be taken care of as per the protocols. Now, when we talk of wet lab, then the second thing, we have a wet lab. Now, how to train the residents or how to develop a curriculum. So for this, we have divided the curriculum into three basic uh, year-wise or three basic stages, steps. The first is the basic microsurgical skills or the beginner level. The second is important cataract surgical skills. And the third is specialty development. So when we talk of the beginner level, they should know about the microscope handling, instrument handling, and suturing skills, about different types of suturing techniques. When we talk about the cataract surgical skills, these can be easily demonstrated in goat's eye, these can be practiced in goat's eye, and there are various other models like rexes in foil, potato peeling, tomato peel, and other things also they can take to the wet lab to practice this under microscope. So the second stage is cataract surgical skill, and the third stage where say a third year resident or someone who has like done the up to stage 2, then they can go into the specialty development and they can actually explore that in which specialty they are interested. Like if they are interested in cornea or in glaucoma, they can practice trabeculectomy flaps and how it is created. For VR, obviously very advanced setup is required, and complication management is also can be there, like a capsule posterior capsular rupture, how to handle that. Obviously this is very much different, not very much, but it is different in live surgery and wet lab, but at least they are exposed to it. Then along with the clinical and the surgical skills, some non-technical skills can also be taken care in wet lab. Nowadays, simulators are also available, but they are very costly. And when we talk about Indian scenario, teaching postgraduate residents, then these simulators are not of much help because of their cost limitation. So that's all from my side. Thank you all for your patience listening. And thank you, WOS, for this wonderful opportunity.
Thank you, Dr. Aditi, for summarizing the last episode and tuning us step by step how we can establish a wet lab. And definitely, in last episode, we saw the wet labs of premier institutes of India, PGI Chandigarh, Chitrakoot, GNEC. And all this has motivated us to improve what wet labs infrastructure we are having to a next level so that our residents are upgraded and they learn in a student learning mode. Thank you, Dr. Aditi. Now let's start with this webinar on evaluation of PG residents. And for the first talk, I would like to invite Dr. Deepti Srivastav. Dr. Deepti, are you ready?
Good evening, Dr. Shweta. Yes, I share my presentation.
She'll be speaking on regulation to reality, what NMC mandates and what teachers must do.
Am I audible and is the screen visible?
Yes, it's visible. You can make it slideshow. And try to stick to the time of 8 minutes so that we can have ample time to discuss.
Yes, Dr. Shweta. A very good evening, respected faculty. I'm tasked with carrying out this presentation on what the NMC mandates as far as postgraduate training and assessment is concerned, and how do we bridge the gap between the mandates and what is actually a real life situation that all of us face as PG teachers. So I'm sure all of you will relate when I say that taking time out from our busy OPDs and OT schedules, and all of us are not just PG teachers, but we are UG teachers as well. So when it comes to handling all of this, there's a lot on our plate. And when along with this, there are a lot of mandates that we need to adhere to in carrying out our PG training program, sometimes it becomes a huge challenge. So how do we bridge this gap actually? Before this, I would like to really ask each one of you, how many of you yourselves have actually had a very structured training or assessment program when you were PGs? I'm sure if I ask you to answer this question honestly, there's only going to be a very few among us, who have had the benefit of being trained in institutes where our PG training was a very structured one. So thus we are tasked with this challenge where we ourselves have not had a very structured PG training and assessment program. But however, now as PG teachers in current times, we have to follow a lot of mandates and carry out our training. So how do we do that? Well, the first thing that we all need to do is we need to actually be well acquainted with the volume, with the content that the regulatory body shares with us, and what is it that is applicable when we carry out this program. So all of this content keeps coming from it has come from erstwhile MCI and now the National Medical Commission, and it gets periodically updated from time to time. So these are some of the documents that are important when it comes to PG training in ophthalmology. And these are also the references that I have used for the content in this presentation. The two most important documents as far as PG training and assessment in ophthalmology is concerned are one is the Postgraduate Medical Education Regulation 2023, and the other is the Postgraduate MSR, which is Minimum Standard Requirement, also which came out in the year 2023. So these are the two main documents that we all need to be familiar with. And the objective of the next 7 minutes that all of us are going to spend together here is that, having gone through all of this content, what I'm choosing to do is focus on the most important non-negotiable aspects that we need to be familiar with. And here, what I have chosen to do is, although the context here is assessment of PG training, we have to remember that assessment is formative as well as summative. So it's a very longitudinal kind of process that starts from when the PG first joins our department until when the PG actually answers the final university exam. So we are tasked actually with being familiar with all aspects of PG training when we actually say that we are dealing with PG assessment. So with that, we come to our topic. And I'm Dipti Srivastav. I work at the Department of Ophthalmology in Goa Medical College. Goa Medical College was established in 1842 and is among the oldest medical colleges in Asia. And Goa is the land of sun, sea, and sand, and that is what my backdrop depicts about the state that I come from. Well, in this slide, you will see that these are the main areas where the PGMER 2023 differs from the earlier regulations which were in force, which were the PGMER 2000. So you see, it actually took 23 years for the regulatory body to, come up with a new program or a revised program for post-graduation. And these are some of the main areas where the PG training program now differs from what was earlier. So let's quickly look at each of them. The most important aspects, is the e-logbooks. So this serves both as documentation as well as an assessment tool. And what the NMC mandates is that the postgraduate student shall maintain a dynamic e-logbook, and it says that this has to be updated on a weekly basis. All our MS ophthalmology students have to enter details of the surgical procedures, not only that they do independently, but also the ones that they assist. What each one of us as teachers needs to know is that NMC has said that it's the duty of the postgraduate guide imparting the training to assess and authenticate monthly this record. So to conclude, what we as PG teachers need to do as part of formative assessment of our PG students is that we have to ensure that they continuously document all the work that they do, both clinical, surgical, as well as academic, and that we periodically validate it, we supervise it, and there is scope for feedback, which means that it is a loop where we help our PG students to do whatever it is that they are doing better. And all this needs to be documented. As far as the platform for e-logbooks is concerned, each one of our college, our institution has to support us with a platform that will enable these e-logbooks to actually function very efficiently, where the PG student as well as the guide can log in to carry out this process. This actually I've just chosen to highlight because all of us are not just PG teachers, but also UG teachers. And we know that in UG, there is a lot of small group teaching, but the biggest challenge is having enough number of preceptors. So, well, in case you're wondering whether you can use your PG students, yes, NMC says that they're essentially required to participate in the teaching and training program. So this also could be an area where you involve your PGs, and it can be a part of their formative assessment as well, where they hone their own teaching skills, even as they are undergoing their PG training. When it comes to research, and what is important here is that it's an eligibility criterion for them to appear for their summative exam, for their university exam. And NMC has made it a little easier now with the 2023 guidelines, where it is any one of the three that the PG student has to do, either a poster presentation, a podium presentation, or it's a research paper, which is either published or even acceptance is okay. But the catch here is that it has to be a conference or journal, which is a dedicated ophthalmology conference or a ophthalmology journal. So this is what we need to know as far as their eligibility to answer exams from their research work point of view is concerned. Again, to be eligible, see, ultimately, when we talk of PG assessment, they have to, in the first place, be eligible to answer that university exam. So one important eligibility criteria is these three important courses that they need to undertake. The BCBR, as we all know, which is hosted by the National E-Learning Platform, NPTEL. In addition, they also need to undergo ethics and a good clinical practices training, as well as training in the cardiac life support skills, both basic and advanced. And NMC says that this has to be done in the first year of PG training. DRP, we all know that the district residency program has been mandated. It's a 3 months program. And this again is an important part because what is important is that they have to receive the satisfactory completion of district residency. It's an essential condition before the candidate is allowed to appear in the final exam of ophthalmology. When it comes to leave rules, well, again, this is important for their eligibility to answer exams. So we all should know that the permitted amount of leave per year is 20 days of paid leave, 1 weekly holiday, so that comes to 52 days, and 5 days of paid academic leave. So this works out to 77 days of 77 offs, permissible offs for a PG student every year. The eligibility is 80%. So 80% of attendance has to be there for the PG student to be eligible for exams. When it comes to examiners, what has changed is that who can be an examiner now, according to the PGMER 2023. So the examiner, both internal and external, has to have 3 years experience as a recognized PG guide in the concerned subject. Earlier, the external examiner had to have 6 years of experience, but now it is made uniform. Both the internal and the external for the university exam has to have 3 years experience as a recognized postgraduate guide. Examiners have to be 4. And what is pertinent to note here is that of the 2 external examiners, it's only one of them that necessarily has to be from outside the state. And in fact, this outside the state examiner has a defined role during the exams, which we shall just see in a while. It is, I think, pertinent to note that we can be appointed as examiners for 2 consecutive regular exams. Just that. It can't be more than 2 times consecutively that we can be examiners for the same institution. When it comes to the theory examination, the NMC says that the theory examination paper can be descriptive type, MCQ type, or a mix of both. So actually, if you strictly go by these wordings, it appears that we can even set an entire paper that would be MCQ type. That is, I mean, the slight ambiguity that is there in these words. But basically what it means is that unlike in the past where MCQs did not feature in the PG paper, now they are going to be a part of the theory paper. The first paper, basic medical science, and the last has to be on recent advances. When it comes to evaluation criteria for the final or the summative exam, the theory papers are 4 in number. Each theory paper carries 100 marks. So total marks for theory paper is 400. What is important is that the minimum passing is 50%. So the PG student has to score a minimum of 200 out of 400 in theory. However, this is subject to the condition that there is a minimum of 40% scored in each paper. So this is a very important criterion that we have to remember when it comes to passing. The other head of passing is the practical clinical part. And here, practical clinical has 300 marks, but it is clubbed with Viva VOC. So Viva VOC now is going to be a part of practical clinical segment. Therefore, 300 plus 100, total it is 400, and minimum passing is 200 out of 400. Here, when it comes to assessment, 5% of these 400 marks are devoted to dissertation or thesis. And this is where the role of the external examiner outside the state is, where it is this examiner actually who is going to evaluate the dissertation thesis and take the Viva VOC on it. So when we conduct exams for PG, this is what we need to remember. The thesis part has to be done by the external examiner who is outside the state. The rest, largely remains the same, but NMC mandates that the evaluation should be digital evaluation, but it will be a digital valuation. And there is no revaluation that is permitted. All the answer scripts will be subjected to 2 evaluations. And only if the difference between the 2 valuations is 15% or more, then only it would be a third evaluator who comes into the picture. Well, while this is what we dealt with were the NMC mandates with respect to assessment, what we also need to know is when it comes to, how we train our PGs, I thought that I'll pick up a few excerpts to just kind of complete the information base for us as PG trainers, that our PG students need to have OT posting at least for 2 full days in a week. Which one of us can be a PG teacher, can take a student? So NMC traditionally has restricted it to professor and associate professor. However, in the PGMER 2023, and this is especially applicable to government institutions, because in government institutions, we do not have time-based promotions. We have post-based promotions. So even if I'm an assistant professor in a college, I can still take on a PG student if I am a recognized PG teacher. And what do you mean by recognized PG teacher? We would have to follow regulations. So the pertinent regulation here has been notified in 2025. It is called the Medical Institution Qualifications of Faculty Regulations. And here what NMC says is that any one of us who has at least 5 years of teaching experience as assistant professor or above is eligible to be designated as a postgraduate guide. So actually, it's important to note that NMC has not mentioned any research publications criteria here. What NMC has said is 5 years of teaching experience in ophthalmology as assistant professor makes us eligible to be designated as a postgraduate guide. And then after 3 years of being a postgraduate guide, we are eligible to be a postgraduate examiner. These are basically bed requirements. I'll skip this since we are focusing on assessment. And last but not the least, when it comes to recognition of our PG program, ultimately all of this is relevant when our PG program is recognized by NMC. So this is one very recent mandate, which is important in the last 2 years, but has been emphasized mainly from 2025 onwards. We need to know that only clinical material which has been authenticated with ABHA ID will be counted for assessment. So our PG training program will be valid when the clinical material that we portray, that we represent or record and show NMC is ABHA ID authenticated. So this is again something that we as PG teachers must ensure, so that our PG programs are continue to remain recognized by NMC. And with that, we come to the end of this presentation. And I'm sure that all of you respected teachers will agree with me that the challenge really is not in mere understanding of the rules, but integrating and translating them into daily training. So longitudinal assessment, formative assessment, in addition to knowing what we really must know about, what is important about carrying out the summative assessment, in addition to all of this knowledge, integrating it into how we carry out our programs, it is what is very important. And I conclude with, while regulations set the direction for PG training, it is each one of us here, each one of us PG teachers, who create competent ophthalmologists. Thank you.
Thank you, Dr. Deepti. That was very comprehensive and very elaborate. I think we also learned a lot because, you don't get lot of times to get through all the guidelines, and you don't read it. So summing up for us was really good for us. So we have here a very special guests. So one of them is Professor Rajesh Joshi, and a very renowned ophthalmologist from Maharashtra, Nagpur, and he has been a PG teacher also. So, sir, we would like to have some comments from you on this regarding, the scope of PG teaching and how generally in government medical colleges with such comprehensive NMC guidelines, how much are we able to follow with this kind of a load that we have of patients?
I thank Mohita madam for this opportunity. I totally agree with what Dipti has said. There is definitely a lag between the course which has been allotted by the NMC and what we follow in our institute, particularly government colleges, because the material is huge in government college. The staff,
Yes.
yes, and whatever things we need to follow according to NMC becomes difficult to follow. We need to have a proper schedule for that. That is very essential, and this need to be understood by students as well. It's not only the teachers'
Right.
responsibility. Students should
Yes.
also go through everything what is being allotted to them by the NMC. So they should also be aware, and each time we keep the schedule, they should also follow the schedule. That is
Right.
important. It's a bilateral thing. That is one thing. And the PG logbook, in fact, I would say that is a good thing. But I have seen most of the PGs, they're coming to us at the end of the tenure, at the end of 3 years before appearing for the exam, for the signature only. And what is there inside, we know that is being copied most of the time from previous seniors logbook. In fact, it should be made mandatory by NMC to do it online, because online assessment will help to judge whatever student is following in their routine day-to-day work. So that is a good suggestion. And as far as research is concerned, research is definitely lacking, because if you see the thesis is not mandatory for appearing for the exam. It just carries 20 marks only. And if you score marks in the rest of the Viva like cases and OSCEs, you need not pass the thesis, you need not do the thesis as well. So research, as far as research is concerned, it's lacking. And most of the things are copied, in fact. So we mentor has to look into it, whether there should not be any plagiarism in performing thesis. And we should give thesis in such a way that is publishable as an article or whatever, case reports or
Right.
case, so that we should also take the responsibility.
Yes. sir.
Thesis
Yes.
only carries 20 marks, so there is uh, as far as operations are concerned, the only 2 days are allotted as far as NMC is concerned. And but how many surgeries we have to give them, what surgeries we have to allot them, that is not very clear from the schedule.
Right.
So that also need to be followed. So
Right.
this is regarding whatever curriculum NMC has given to us.
Right.
Over to
Agreed, sir. Agreed, sir. Because it's a two-way process. I understand, and with a lot of work that goes on, clinical work also, it sometimes become a little constrained. But I'm sure the guidelines that have been put by NMC, and especially the video recording during the examination process also adds a little more credibility to the examination system overall. So here we have, in contrast, Dr. Sujata Das, and another special guest here, and she is heading an institute that is par excellence and has a very different setup for the PGs or DNB candidates that she has, mentored. So, do you think how feasible it is in an institute like yours, to follow these guidelines or the DNB guidelines or any other PG program that you run?
Yeah, thanks, Swati, and thanks, Dr. Sita, for including me for this meeting. Actually, nice talk by Dr. Deepti. Yeah, definitely it is a challenge. Whatever Dr. Joshi told, I completely agree. First, let us come to the logbook. Logbook, our DNB student used to manage with a hard copy, and they get it signed once it can be done fortnight, but once they finish the department posting, they go to Konya, then they go to Glaucoma. Before that, I was asking them to do the retinoscopy also. It is not only surgical logbook. It should be interesting cases also. They should finish this many retinoscopy, this many number of applanation, practice suturing. All those should be in the logbook rather than only surgical training. And thesis, we usually ask them to do the literature search at the beginning and come out with few ideas. Then we should see, like, unlike some colleges, they will ask what are the thesis done. Ideally, it should be what is not done rather than what is done.
Right.
Otherwise, people just copy the thesis and for secondary DNB, it's sometimes a challenge to do a prospective study, but primary DNB, especially 3-year MA student, they can always do a prospective. We prefer to give a prospective to primary DNB and maybe ambulate prospective plus retrospective for the secondary DNB because they have practically 1 year. And as Dr. Joshi told, we should have some cut-off number. This many SICs, this many FICO, this many corneal tear, pterygium, rather than just the 2 OR in a. And our DNB student, because they go to secondary center, they do a lot of surgery and learn to do independent decision rather than always under the cover of consultant. So they can either go to the district headquarters when they're 3rd year or 2nd year so that no independent decision making. And publication, definitely, I feel they should start writing the thesis as a review because anyway they do literature search. So they can write a review article based on that and maybe mandatory one case report, one case series because thesis publication will take time. Once they appear the exam, only they can do. I think from the first day, if we give them the like first 1 month you finish this next 6 months you finish this, then maybe it is easier. Because ethics and all is mandatory for nowadays for all, for DNB as well as PG. So that is like that we have to make the planning from the beginning of the PG, then only we'll be able to finish it.
I think we totally agree with you, Dr. Sujata, and also with Dr. Rajesh that, there has to be a minimum number of surgeries and clinical procedures that have to be given. Plus, the logbook has to be updated, time to time. And they should, and in fact, as mentors or thesis guide, we should also make sure that they come out with publications as much as possible because I think that's the best time to have publications mentored by somebody. So thank you so much for your thoughts. Now we move on to our next speaker for the day, Dr. Shreya Thate. She's a professor from Shri Aurobindo University Medical College, and she's right now in Indore, Maharashtra, Madhya Pradesh.
Okay.
And she's a very prolific ophthalmologist and a surgeon. So over to you, ma'am, for speaking on designing fair and objective OSCE stations.
Thank you, Swati.
Yeah, and before we start with Dr. Shreya, we have Dr. Mohita who has joined in with us. So, Dr. Mohita, we would like to have your comments on this also.
Good evening, everybody. Sorry, Dr. Shreya, for
No.
making you wait. You can continue if you want. It's not, or I'll just say two sentences that it is definitely a pleasure to see you all get together and discuss these topics that are for the betterment of the students, and the whole concept of WOS is mentoring and the mentor-mentee concept. And this is coming out so well in this Teachers Connect program. And actually these programs are something which you all are discussing, something which is discussed nowhere, no other webinars is discussed, no other meetings it is discussed. So I'm sure some very good outcomes will come out of this. But our whole idea is also that when from whatever is discussed, we compile all this and sorry so we compile all this and take it out in the form of a guideline or a publication which could help all others. So please continue. I am a listener today, and I want to listen to all that is being discussed today in the webinar.
Thank you, Mohita. Thank you, Mohita. And thank you, WOS, for starting this very wonderful program and very useful program. And in this, I'm going to talk about the designing fair and objective OSCE in ophthalmology. So what is OSCE? It is a multi-station structured examination assessing the skills of clinical competence of history, examination, procedures, and management. This eliminates the subjective examiner bias by using the standardized checklist, and it used for undergraduate as well as the postgraduate. This also offers the innovative, objective, and fair methods of clinical assessment. So this approach is for formative and summative clinical evaluation on large student number within a short time, where students perform the similar clinical task and their performance is graded against the predetermined scoring scores. And this promotes the uniformity, validity, and reliability. So this includes all the three domains. I don't know what is happening. Just a minute. This includes all the three domains: affective, cognitive, and psychomotor domain. So why we need this objectivity? This objectivity of assessment is for reliability, validity, and fairness of the examination. And to get all these benefits, we require time and person to design this OSCEs. And we need substantial preparation and planning, because poorly planned and designed OSCEs, they compromise the accurate implementation. And this leads to questionable credibility, uniformity, validity, and reliability of the results. Therefore, OSCE planning and designing must be based on the research standards. So there are certain key steps in designing the fair OSCEs. We will come one by one and include all these things. So first step is to develop the policy framework. This is very, very essential to frame the policy. And for this, we can design the committee. And in this committee, there are educational experts are there, and they will decide upon the standards of minimal resources like space, mannequins, or trained examination. They can select the moderation criteria, even the criteria for the tools which we are using in the OSCE, and they can form a system for the uniformity. So it starts in time, and time per station can be decided by this committee. And they form a system for management of OSCE score variances. The second step is blueprinting and mapping of the content. This blueprinting aligns the OSCE content with all the curriculum learning objectives. Like if there are sufficient stations, they should cover adequate content aligned with the clinical competencies. So almost all the competencies and varieties of domains should be included in this OSCE, and they can be verified with the blueprinting tool. This OSCE designing, once you do the blueprinting and mapping, then we have to select the different station writers. And this educational expert in the committee, they can help them, they can guide them, they can coordinate them how to write the OSCE stations, and they have to frame the OSCE stations. And in this OSCE station, they must include the essential contents. It can be OSCE station, can be 10 to 20 station of 5 to 10 minutes, depends what is the task given to them. And they can be of different variety, unobserved, observed, with including all the domains. Main aim is designing the OSCE is to evaluate the domains for learning, maintain the uniformity and standardization in all the stations. So this OSCE station should be very effective. The instructions to the candidates should be given in very clear. There should not be any confusion. Proper time management should be there. And you can include the real patient or images, simulators, and there should be varieties of the station, including different domains. So this is one of the example where the task is given is the demonstrate the distance visual acuity testing in the patient. So competency is to demonstrate the steps in performing visual acuity testing using the Snellen's chart. And this is for the distance, near, color vision, pinhole. But this whole competency is difficult to include in the this OSCE. So we can just give distance visual acuity testing in that particular patient. And what we expect in the student, that they must ensure the adequate illumination, testing the eye one at a time, first without and then with the glasses, keeping the Snellen's chart at 6 meters. So all these things which we do in routine regular practice, whether the patient, this candidate is doing that thing or not, this should be the expected. This is just like a checklist to the examiner, and accordingly scoring system can be formed. So the uniformity of the scores is there. There will not be any bias system. The third important step is to develop a bank objective stations. So once we have designed the OSCEs, then we can form the different varieties of OSCEs, means different categories of OSCE, with few with the equipments, few with the patient related, case related, or some affective domain OSCEs or cognitive domain. So we can maintain those OSCE banks, but before incorporating all these OSCEs into the bank, it is always recommended that they must undergo the peer review, piloting and psychometric analysis. If they are there is no discrepancy, then only they should be included. The scoring is very, very important, and it should be based on the demonstration of the clinical skills. We need to choose a checklist to evaluate the actions, as I have shown you that example. So accordingly, checklist is prepared and which is given to the examiner. So there is no question of bias or no discrepancy is there. Like this question, demonstration of the instrument. Here task is given, demonstrate true IOP recording on Goldman applanation. But what model questions are given to the patient, the student, is identify the instrument, what is the use of instrument, principle, what is the normal IOP, precautions, and what are the different errors. This is not correlating with the task. So such questions cannot be given. So we need to give in this demonstration, we need to just observe the student, what they are doing, and these are the expectations from the student, whether they are introducing themselves to the patient or not, explaining the procedure, checking the setting, positioning the patient correctly, or taking the this recording correctly, whether they are cleaning the applanation prism after the use or not. So these are essential part of the IOP recording on Goldman applanation, and say these are the expectations. So accordingly, we can give them the scoring system to the examiner. So there is no discrepancy again. So all the steps are included, all the checklist is included in the scoring system. So we can give the binary scoring system like yes or no, whether he has done that thing or not. If it is done, then you can mark 1, yes or no. But no way criteria should be there. So it should be very crystal clear to the examiner as well as the student. So for the cognitive domain, you can give a fundus picture photographs, describe the fundus picture, and here expectation from the student is whether he is identifying the fundus photograph with the eye, which eye, right or left eye, describing it properly, that media, disc, color, disc cup ratio, background, what is the differential diagnosis, what is the probable diagnosis, and what is the clinical significance of this disease. So if they are explaining all these things correctly, and accordingly we can distribute the mark, whether half marks or 1 mark, depending on the significance and importance of that particular subtask. Then very important thing is to train the recruited examiners and standardized patients. So we have to develop the OSCE examiner training program to train the examiner according to the minimum assessment standard. So we can provide examiners to practice scoring. We can give them checklists, we can give them OSCEs, how to conduct the exam and how to check the checklist and how to give them scoring. Similar way, we can train this standardized patient, because patient is going through the same type of questions or same type of tasks for a series of students. So they should be cooperative, they should understand what they are asking. If this OSCE designing committee feels that this patient is not able to answer properly, is hard of hearing or something, not cooperative, so that committee cannot has authority to not to allow that patient to take part in this OSCE. So in such situation where patient is not consistent in behavior or acting or giving response to the questioning, so training is very important. If it is not there, we can include the nursing staff or senior resident for the role play and other things. Examiner training, how to use the checklist and prevent the lenient or harsh grading. So we have prepared that checklist, so there is no question of any harsh or lenient grading. So they must understand when to give how many marks and what marks are given to one particular subtask. And there should not be any conflict of interest. No examiner should grade their own students. There should be. So this is another clinical scenario where the picture is given to the student and just ask the task, sudden painful red eye with nausea halos, how to manage. I think there is some confusion for the patient. So in place of that, we can give the clinical scenario like 58 years old, hypermetropic female, presenting with the sudden onset of severe pain in the right eye, redness, blurring of vision, colored halos, headache, nausea, vomiting since last night, and she gives a similar history in the past. So clinical scenario is there, clinical picture is there. Then you can give the model questions like most likely diagnosis, what are the clinical features, what is the immediate management, and what is the definitive management, and if what are the complications if it is not treated at that time. So the instructions given to the students should be very crystal clear, and accordingly we can give the model questions or the task which is given, we can observe that, and accordingly the OSCE key or checklist is prepared, scoring system is created. So another the OSCE is counsel the patient on cataract surgery. So this is so many things are there while counseling the patient. So you can just give a clinical scenario, 65 years old patient with senile mature cataract, counsel the patient regarding the condition and its management. So it is easy for the students to understand, and in that particular given time, he can ask the patient whatever has been given task to him. And according to that, we can form the scoring system and given scores to the student. So selection of appropriate venue is another very important thing. You have prepared very good OSCE, everything is checked. But if the venue is not proper, there is not proper space for the 10 stations to run or 20 stations to run, along with the keeping the simulators, trainers, and even many times we need the recording system also. So these things are not there. So it is not conducted properly. There should be proper waiting space. So this should be inspected before conducting the OSCE by the OSCE designing committee. So before conducting the OSCE, actual OSCE in the final examination day, it is mandatory to do the station piloting, just to recognize and rectifying the practical discrepancy and ensuring the impartiality and feasibility within the recommended time. We have given a task. If it is not able to fulfill, if we feel that this is too many things we have given, so we can cut down in while doing the piloting. Examiner is familiarizing with the OSCE is again important, because he must know what are the prerequisites. Suppose he is asking the student to perform the indirect ophthalmoscopy. Indirect ophthalmoscopy is there, 20 diopter is not there. What is the use? So he should first confirm that what are the prerequisites, whether they are there or not. Then only we can conduct the OSCE properly. This is another clinical. If patient is there of proptosis, so there is competency also. So all the stations should be on the competency. So as per the situation, we can expect the student from what they have to do, what they are expected to do, and accordingly we can do this system scoring. So before actually going for the OSCE final examination, we can do the pilot testing by dry run to check the timing and clarity, analyze the results, whether it is unusually high or unusually low, means there is some faulty station is there. So we can change at that time, not during the final examination. This example I was giving you, that indirect ophthalmoscopy. So what we expect, whether he is introducing, whether he is taking consent from the patient or not, preparing the instrument properly, adjusting the IPD, doing the correct way of indirect ophthalmoscopy, then whether he is doing indentation or not, whether he is drawing the fundus chart correctly or not, and accordingly marks are given. So there are certain challenges and solutions are also there. Time. Many times it happens that we are looking for a watch for the time, and we may miss few seconds or few things. So there may be some so you can use at that time automated timing. Material, sometimes patients are not there, so for the role play, for the counseling type of stations, so we can use the trained nurses or senior residents. And for the faculty also, if you are asking faculty at the same time check this thing, so it is really difficult. So we have to provide training and demonstrate the reliability data. So in conclusion, OSCEs are very, very essential for the clinical assessment. A well-designed OSCE relies on the solid blueprinting, structures checklist, and trained examiners. The fairness is ensured through the standardization and piloting. Thank you.
Thank you, ma'am. Thank you. Thanks a lot for covering all the pertinent points, and that was such a enlightening talk for all of us, because OSCE is something which is very scoring part of a postgraduate examination. While we take it very lightly, means after listening to your talk, I feel that there is a need for training for us also, how to
Yes.
standardize the OSCE and how to make it in a comprehensive way that it should cover all the clinical competencies, and very enlightening talk. So we have so many panelists with us. Dr. Alka ma'am is there, Dr. Swarna ma'am is there. So Alka ma'am, I would like to have your comment upon what ma'am has just talked upon, that the OSCE is very important part, and how can we improve so that it can become more standardized in our future. Welcome, ma'am.
Thank you, Vaya. It is really very heartening to listen all these things because we are there in this area for such a long time. And as in the beginning, they said that we haven't gone through all these things, but definitely we have to go for these things, and we have to take care of the students that they are becoming expert in their field. So both the talks, Dr. Shreya also told us very nicely about this OSCE part. And we are all doing this and it is really important to teach our teachers also, so that they can take this OSCE part in a standardized manner. So thank you so much, and I think it is a very interesting and illuminating talk. Thank you so much.
Thank you, ma'am. We have Dr. Pooja Hingorani, ma'am, with us from Nagpur. Ma'am, what is your take upon how can we improvise ourselves, and what all things should be included, what we are missing upon? Like, I think that there are like 2 days or 3 days exam, and we feel that there is some repetition of the stations, and the later batches, they come to know what is the pattern which is, being followed in the first batch. And so how can we make it more standardized for each batch? Yeah.
Yeah, first of all, thank you for having me here. And I am aware that all patterns are very different. The NMC follows a different pattern. DNB used to have OSCEs since many years. In fact, when I gave my DNB exam after my MS exam, that was just the second batch having OSCEs. So we had no idea how we have to prepare, etc. But over time, as we have started teaching students and including OSCEs, we at AIMS, though we have an autonomous system where we can include our own setup and our own percentage of how many OSCEs we may or may not have, we always choose to follow NMC. Most of us, most of the departments, because it has been very sensibly designed. And I always borrow from the fact that during the DNB OSCEs, of the 25 OSCEs we had to go through at that time, there used to always be a set of observed OSCEs. So not only there should be like a table viva kind of thing where so when we distribute OSCEs, we have a percentage like there have to be so many observed OSCEs. There have to be so many OSCEs where there has to be some form of performance, right? The student has to be seen doing something. Then there can be OSCEs which are maybe based on histopathology or based on microbiology, because we tend to forget these things. So if we have one compulsory OSCE for a microbiology or for a histopathology, then the students know and we are evaluating them on many fronts. Another thing is, of course, clinical photo. Like ma'am has already discussed a clinical photo. And also, time and again, I have attended sessions where OSCE evaluation and the way we give the the checklist can be very, we are checking the wrong thing sometimes. So sometimes we are checking whether the student washed his hand, but we are not checking whether he used his right hand for the right eye, left, or simple things like that. So when we know, we can start changing the checklist. And I was very happy with the way ma'am said that there can be an entire committee who can oversee these things and maybe standardize them. And best of all, this idea of an OSCE bank, which is something very novel. I've heard it for the first time. So I'm, Shreya ma'am, I am really so excited about that. If we can all have a bank which is more or less standardized, peer standardized. So, but we should realize that we have to make them do certain things, and we have to cover things which we cannot otherwise cover on the OSCE stations. So maybe an instrument, maybe different types of instruments in certain OSCEs, maybe like microbiology, histopathology, maybe some syndromes, maybe USG, maybe CT scan, maybe MRIs on one station. So if we have a definitive principle on which we have, so maybe one OSCE will be on a radiology, one will be on ocular investigations, one will be on optical investigations, and so on. So I think it will help us categorize and give a standard, as well as we can have repetitions also. We can have optics and transpositions also. So we do a lot of these mix and matches. So that helps us to cover the entire portion. And it also gives us alternatives. So if today I've kept gonioscopy, tomorrow I might keep slit lamp evaluation and so on. So it need not overlap. I mean, it's similar and yet doesn't overlap. Thank you.
So, Dr. Pooja, I think WOS can take an lead in this, and we'll discuss in the core committee, and
Yes, ma'am.
we'll pen down all the competencies and at one place, and then we can ask for the volunteer who can make a scenario or submit an OSCE on one competency, and WOS can create an OSCE bank which every one of us can use, and we all can standardize that. We'll take a lead on this and we'll definitely work on it. Dr. Maya, what is your take on this?
That's a brilliant idea. Thank you for that, ma'am. Yeah.
Yes, definitely. And I agree with Pooja ma'am that we should include the allied specialties like ocular pathology, microbiology, radiology also in, to cover all the competencies. So that is very good idea. Usually we forget about the micro and pathology evaluation, and we just restrict ourselves to clinical, topics. So that's a good idea.
Can I add something? What we are doing in our department, we have different subspecialty faculty also. So I just give them task. You prepare for the refraction, you prepare for the pediatric something or glaucoma and retina and like that. And for the radio imaging or pathology also, we have different slides, and or we select and prepare OSCE accordingly. We check and then we rotate if you find some flaw or something, so accordingly. And we have at least for each category, we have many OSCEs prepared, and they are already prepared and laminated. So we can very immediately we can change the OSCE. So that's why it is very easy, not before the examination, but we prepare very early, even 6 months before. And every year we try to create more OSCEs. So new thing is coming up with that. So this helps us a lot.
Ma'am, what I had observed is many times we have questions, but for the evaluators, the checklist is missing. So besides creating a station, the checklist must be there. An important thing while evaluating, the evaluator has to be on mute. He can't ask anything from the student. He has to just observe what the student is doing. This is missing actually. The teachers also prompt the students the questions. They give their feedback right at that time. So all this training is actually needed, and definitely we'll work on it and we will improve. Swarna ma'am has to say something. Swarna ma'am?
Yes, yes. Shweta, I think it will be better if we have periodical evaluation of OSCE also. When the students comes, we should have the evaluation of the clinical actually subjects and what they have done in 3 months or 6 months. At that time, they can practice the OSCE evaluation also.
Yes, ma'am. It should be a part of the formative assessment that is
Yes.
done every 6 monthly. That is done. It must be a
Now,
part of that.
even
Very well,
frequently, so that they will be trained in that one.
Very true, ma'am. Very true.
Okay. So now I think we can move on to the next talk of the session, and that is by Dr. Kushnood M. Sheikh ma'am, and she is from GMC Government Medical College Surat, and ma'am will be speaking on evaluating case presentations, making long and short case objective, structured and defensible. Over to you, Dr. Kushnood. You can start sharing your screen. Are you here, Dr. Kushnood? Yeah.
Yes, I'm here.
Yes.
Yeah,
Yes.
I'll start sharing my screen. Good evening.
Good
Good
evening.
evening, everyone, and good evening, respected. Am I audible?
Yes. Yes.
Is my screen visible?
Not yet.
Okay. Now it is visible.
Yeah.
Okay. So good evening, respected dignitaries and dear colleagues. Myself, Dr. Kushnood Sheikh, working as a professor in the Department of Ophthalmology at the Swimmer Institute of Medical College at Surat. I'm sorry, it is not GMC. I'm very sorry, Dr. Maya. And I thank you, Dr. Moita, the team boss, and Dr. Shweta for giving me an opportunity to speak on the evaluating the case presentation, making the long and short cases objective, structured, and defensible. So for the objectives for the today's sessions are it will be the analyze the limitation of the traditional case assessment, explain the principles of the structured, objective, and defensible clinical evaluation, application of the EPA, that is end testable professional activity, and rubric-based scoring for long case, and justification of the marks using them defensible calculation methods. So why do we need a structured case evaluation? As we all know that in a structured case, in a traditional long cases, there are high subjectivity of the different examiners. There is a poor interpreter reliability, and there are chances for feedbacks are very less to the learners. And now it is a time for the defensible assessment to make it more measurable and valid, and it should be documented. So assessment principles are whatever we are assessing, that is the long case or whatever, it should be a criterion reference assessment where the students are assessed against their predefined standards. It should focus on the competence, clinical reasoning, and patient satisfaction and the performance. It should be valid, transparent, and reliable. What to assess? As we all know, as we have discussed, that there are three main domains. That is the cognitive domain, the psychomotor domain, and the affective domain. So we have to assess according to the domains which are been given. That is the psychomotor skills, and the affective domain will include the communication and the professionalism. So long case evaluation domains will be the history, clinical examination, interpretation and clinical reasoning, diagnosis, and differential. So it has a marks which I have divided as per the, if the long case is of 100 marks, I have divided them into the history will be carrying the weightage of 20, the clinical examination will be of 30 marks, clinical reasoning and interpretation will be weightage of the 10 marks, the diagnosis and differential will carry the weightage of the 10 marks, investigation 10 marks, management plan 15 marks, and the communication and professionalism will carry the 5 marks. I'm unable to share my screen. Is it seen there? Hello?
No, your screen is gone.
Yeah, that is what I'm unable to share. Yeah, is it visible now?
No,
Not
Hello?
yet, ma'am. Not yet.
Now?
It was visible earlier.
It was
Now it is
visible.
visible?
No, I think you need to share it again.
Okay, I'll just see. I'm sorry for that. I don't know what happened. Is it visible now?
No, ma'am.
Oh, no. Wait.
The technical team can help, please. Ma'am, you can stop share and then
Yeah, I'll do
again.
that.
Yes.
I think the time it is showing that your time is over. I don't know why it is showing that.
No, there is no timer.
That is what it is showing me, that your time is
So
about.
should I share it for you? Should I share it for you?
Yeah, definitely. Yes. Please, can you share the slide, please, Dr. Shreya, Dr. Shweta, please.
So is the screen visible?
Yes.
Yeah. Yes, now it is visible to me also. So
Just
the
a
long case
second. Just a
please.
second. Just a second.
Okay.
Yes, perfect.
Is it okay? Shall I start? Am I
Yeah,
audible?
please. Yes, please go ahead.
Okay. So the long evaluation, long cases has been divided into the certain domains as I have talked previously, and it has been given different marks, that is 20, 30, 10. Differentials includes the 10 marks, investigation 10 marks, management plan 15 marks, and communication and professionalism 5 marks. This is when we are having a long case. Most of the colleges is of 100 marks. Then it is possible. And for the short case evaluation, if the short case is of 50 marks, we can have a focus history for 10 marks, focus examination for 10 marks for that particular case, interpretation and investigation and management outline, all of them for the 10 marks. If it is of 30 marks, we can adjust that accordingly for all particular domains. So how do you calculate these marks, and how do you make it objectively, and how do you make it reliable? So this can be happen is by use of rubrics. And these rubrics are the analytics tool that define the performance at the different levels. That is, each domains we will be giving the 4 levels of a rubrics. That is excellent, good, average, and poor. And then each domain will be assessed independently. This will reduce the examiner variability, and this will improve the consistency and reliability. And there are certain descriptors what we will be assessing at that and to whom we will give the excellent, to whom we will give the good, and to whom will be the poor level while assessing the student. So descriptors are the when the student will answer the or present the history. If suppose we take the history presentation, and history the marks for the history is a 20. If the student is giving the proper complete history with the proper accurate, with all the positive and the negative history system in a systematic way, and which is relevant to that particular disease, then he will carry the level of excellence. Similarly, for a good, if they have some certain omissions, but they found to be a clinically sound and it is near to complete, then they will give the level of good. And if they are incomplete, it is average, and if they are very incorrect, then it is a poor. So for all domains, we'll have that type of descriptors for a particular case, like for a glaucoma, for uveitis, for a retinal detachment, and then we will analyze it. So another method of calculation or another method of giving student evaluation is for a long case evaluation is an untrustable professional activity. And in that there are 5 levels, and this is based on their independent performance, whether the student can do the whatever the treatment independently or not, or for example student can do the surgery independently or not. And for that there are 5 levels, starting from the level 1. Level 1 I think is for the first year, and level 5 is for the senior resident. And we expect for the PGs to reach up to the level of level 4. So this untrustable professional activity will give us the idea that can this postgraduate manage a similar patient independently. That is the question, and untrustable professional activity will give us the judgment that this student can be given the can handle the situation independently. So how do we calculate the rubric score into the marks? So as we have discussed about their domains, and that domains have the different marks. So we have to prepare the blueprint for that particular domain. And the highest rubric score for that, all the domains are level is 4. That is excellent, good, average, and poor. So that is 4. So we will have to identify the multiplier. And this multiplier is identified by the domain marks. Suppose for the history, the marks is 20. Or for the clinical examination, the marks is 30. So that is a domain mark, which will be divided by the highest rubric score is our 4. If suppose we keep it 5, then it will be divided by 5. And the final marks will be the rubric score will be and multiply by that multiplier. So with this, we can give the marks, we can convert the score into the rubric level into the marks. So this is the example of the conversion from the rubric level. Then the scoring the principle are the assessment shall be structured and focused. That is one thing. And marks should be avoided for the correct technique, relevant findings, logical interpretation. If the students do any minor mistakes, they should not be given any harsh penalty. Standardization and reliability measures are to improve the reliability and reduce the examiner bias. one should use the common marking rubrics across the examiners. As Shreya madam has already told, that orientation of examiners before examination is very much essential. Use of domain-wise marking and not a single global score. Documentation of marks for each component. Avoid the comparison between the candidates. And for reasons for a very high score and very low score should be documented. Why this method is defensible? So this method is defensible because there are all the criteria what we have set is on the domain base, and we have given the descriptors also, and we have given the guidelines to the examiner. So it is a transparent criteria and it has a scoring system. It is aligned with the CBME. It improves the reliability, validity, and transparency, and it is suitable for audits and review. So, for example, if you have a case of a glaucoma, how we will evaluate the long case of a patient or a student have given a case of a glaucoma. Here, the history taking we have said before that history taking carries the weightage of the 20 marks. If the student says that the student present all the history without any wrong answers or without any flawless, without any missing any points relevant to that disease, such as gradual painless vision loss, all the risk factors are covered, use of steroids has been covered, compliance, whether the patient is compliant or not, or since how long the patient is using the drug, systemic history associated with, everything is every history is covered, then that student may score the excellent level, and we can convert that excellent level to the marks. Similarly, for clinical examination, we can divide it into the anterior segment, where the weightage will be of 15 marks. Posterior segment again will be of 15 marks. Interior segment covers all the examination part starting from the lid, adnexa, cornea, and pupil, anterior chamber, von Herrich's classification, pupillary reaction, and everything. The posterior segment, the student will speak about these starting from the media to the disc evaluation properly, the size, shape of the disc, the cup disc ratio, whatever the soft and the hard science of the disc. If everything is spoken by the student, then they will carry the excellent score. Similarly, the interpretation, whether they are correlating the IOP and the history, the duration, the visual loss, disc changes, no fiber layer defects, and they are giving the clinical reasoning for that interpretation. Diagnosis and differential can be whether they reach to the correct diagnosis and they are giving the differential diagnosis with the proper justification. Investigations, what investigation is actually required for that particular patient should be answered by the student, and other investigations which are relevant to that particular case should score the excellent. The management plan, of course, whether the students is discussing about the target IOP, medical and the surgical therapy and the follow-ups, what follow-ups and how frequent follow-ups are required, that will be carry the excessive level of the rubric. And and the last is the communication and the professional. The behavior with the patient and the talking with the patient is very important, and of course explanation of the chronic nature of the disease and the lifelong follow-up emphasis is also important in that professionalism part. So in this way we can evaluate the case for a glaucoma, and where we can give the different level rubrics in the form of a excellent, good, average and poor. So take-home message is the clinical assessment must be criterion reference, not based on the comparison between the candidates. Structured assessment improves the fairness and transparency. Domain-wise scoring is essential for legal and academic defensibility. Rubrics convert the judgment to the marks, and linear scaling ensures the objectivity. These are the references. Thank you very much.
Thank you, Dr. Khushnud, for such wonderful presentation and making the job easier for, I think, everyone, all the teachers of present over here, how they need to evaluate the long and the short case, how they can make it structured, because it is like we have to give long case marks out of 100 and we just write 60, 70, 75 without considering how we are giving these marks just by Sometimes many of us may be giving 60, another examiner would be giving 70. But if it's structured, then everyone will give a similar number of marks to all the residents. So we have with us Dr. Jigisha Sharma. Dr. Jigisha, what is your take on making long case and short case structured while we are evaluating them?
Yeah, good evening, everybody. At the outset, I'll congratulate WOS for these fantastic modules that have been created for the Teachers Connect program. I think all of us are getting to learn so much, and at the same time, we are aware about what is happening at the other places so that we can improvise on our programs. And I'm sure there's a lot to learn for all of us. So, regarding the long and short, as you rightly said, there is no standardization happening right now. It's so subjective, and it all depends upon the examiner. It all depends upon the way he's been conducting his exam. So when I go as an external examiner, I am doing what I do otherwise at my place. So if there is a standardized protocol like what Kushnun madam said rightly, the rubric system and all is very interesting, and I think if we can standardize it, there will be a universal way of assessing all examinations, and all of us will be more or less on the same page when we are assessing the candidates, which is I think the need of the hour, because every student is being assessed at a different level by a different examiner at a different center. So there is really no standardization as of now, as far as I understand. So I think this is going to really be very helpful, because OSCEs I think we can still manage, but this is very subjective, the long and short case thing. So introducing something like this, and if we can have a standardized protocol like what you said, that we will do a PDF and WAS can give a booklet or something as guidelines, I think that will be really very helpful to all of us, and in improving our assessment skills. So I think this is a
what we keep while we are evaluating the residents is a single sheet. So what if we are taking Viva of 5 students, then for each student we can have a checklist or a marking list for a long case and short case and fundus,
yes.
and for everyone like this. If we keep, and then we can definitely some structure
and at least 4 headings under which we are assessing,
yes,
broad
yes.
headings.
Correct,
at least
very
broad
correct.
headings, that these are the 4 headings on which we have to give marks. Then I think we'll start making much progress in the standardizing protocols.
Very correct, Dr. Jigisha. We also have Dr. Urmil Chawla, who is very senior ophthalmologist from PGI Rohtak. Dr. Urmil madam, can we have your comments and
Ma'am, you are
inputs?
on mute. Ma'am, please unmute.
Good evening, everybody, and thank you, WOS, and thank you, Shweta, Maya, Swati, and Moita ma'am is not there, for this opportunity and the wonderful program you have put up. And as everybody is discussing, it is very, very rightly said that nowadays the structured marking system is very good. I remember the first time, long back, when I had gone first time to as an DNB examiner, I was really surprised to see this, because they have been following this since long. And even when I came back, I discussed it in my department. I insisted, but this is really very good. We should follow it, because the way we have been following is very subjective. As Shweta said, one examiner may give 60 marks, the other may go to 70 marks. So even when we do a UG exam, then also you will see we sometimes land up scoring like in this way. So this structured stepwise, like history will have this much marks, your case presentation, your clinical, your this thing. This gives a very good marking system, and this is helpful for the students also. I feel when we check the theory exams also, theory papers also, the marking and dividing system which the NB is following is very good. We should actually incorporate it in our routine also. This gives a good chance for the student to score marks also, and the failure rate also reduces. And the very one important tagline which I took from Dr. Khushnood's was that the examiner should be oriented before the exam. Previously, we used to just walk, matlab, exam lene jana, theek है, as a student, but nowadays going to take an exam is equally important as the student is appearing. We also need to go prepared with certain things, with our subject matter, and also the way we are going to conduct. And I also feel that wherever we go, the uh, person who's in charge of the examiner should 5 minutes address all the examiners and update like what kind of pattern they wish to follow and what is the scoring system they should follow. And that really updates everybody and is helpful also. This is what I would say. Thank you.
Thank you, Dr. Urmil. And in fact, we can also tell the students that you will be evaluated on these points.
Yeah.
So they'll also emphatically cover those points when they are taking the case. Many times they also don't know that on what points they are being evaluated. And many times the viva goes haywire. It has to go in some other direction, and we examiners only take that viva in the other direction. Maybe those points, if there is a checklist, the viva will be go straight in one line, whether he has covered those points or not.
Definitely. Thank you.
Shreya ma'am, do you have anything to add to what we are discussing?
Yes.
Yes, ma'am. Yes.
This is really
Yes,
very nice idea to categorize the standardization for the long case and short case. Very well said and very well. I think we must include in our examination, and not only final examination, but when we are doing this 6 monthly or when we are
formative
taking,
assessment.
so that time also we can incorporate, so that student they know what are the actually steps we have to follow and what we have to include. That's very good idea.
Yes, ma'am.
Yeah.
Thank you, ma'am. Swarna ma'am has to add something. Swarna ma'am, please.
Shweta, we should have an orientation meeting as soon as we get the students. And we should make them aware about all these proceedings so that they will not be confused and they will be prepared.
Yes, ma'am. Very correct, ma'am. Orientation is very, very important. What is expected out of the student and what is expected from the teacher, it must be clear on everyone's part.
Yes.
So I think we had a wonderful discussion on very salient, important points that are very, very practical, and and this was a need of the hour so that we can implement CBME in our PG teaching also.
I think,
So
Shweta, we can open the panel for any other panelist who wants to, add on to this, or somebody else who wants to speak or have any other idea. You're most welcome. Okay. Yeah. Shweta, you can go ahead.
So with this, we come to the end of this webinar, step 5 of WOS Teacher Connect on evaluating our PG students. And I would extend heartfelt thanks to our special guest, Dr. Sujata Das, for being here right from the starting till the end, seeing the deliberations and motivating us. Thank you, ma'am, for joining. I would also like to thank our esteemed panelists, Dr. Swarna ma'am, Dr. Urmil Chawla, Dr. Manisha Rathi, Dr. Devang, Dr. Jigisha, Dr. Rupali, Dr. Pooja Bang, Dr. Soumya, Dr. Shweta Partha, and Dr. Bubhuti. So thank you,
yes,
everyone.
we can have, yeah.
So we can all switch on our cameras and we can have one group photo.
Please,
Sharik, can you please take a screenshot?
Sure.
Thank you, everyone, for joining at dinner time. Though we are all passionate about teaching, and that's the reason why we are sitting over here. Thank you all for joining. Thank you, WOS, for giving us a platform.
What a nice organizing this.
Yeah, it was a wonderful session. I think we all gained a lot. Thank you so much.
Thank you.
Thank
so
you.
much.
Thank you so
Night.
much.
Yes.
Good night.
Yeah, thank you. Bye.
Thank
Good night.
you. Good night.
Good night.
Bye.
Good night. Bye-bye.
Bye.
Night. Very, Shweta, very informative.